Okay, welcome to Simply Psych EDU. This is the last part of the 5-part ADHD series. Today we're going to be talking about the stigma associated with adult ADHD. We're going to annihilate the common misconceptions and myths about adult ADHD. Fortunately, I have no financial disclosures. I do not get paid to do this, and I have not received any compensation from any other entity. These are my medical legal disclosures. Remember that this is just an educational podcast. This is not, or should not, be perceived as professional medical advice. Information here should not replace the medical advice of your physician. I'm not a child and adolescent trained psychiatrist, and my opinions are my own and they do not reflect the opinions of any institution. And then the last thing, the patient who we're going to be discussing today, LB, who I introduced in the very first lecture, gave consent to speak about her case and was very excited about sharing her story. Some of the diagrams and information in the presentation come from various textbooks. Here's a list of 4 of them that I've used. This is not the only 4, but these are the most used throughout these. These are the most used throughout this presentation. That's me. Learning objectives have not changed. So I showed this slide in the very first lecture, and I just wanted to reiterate that clinical decisions come from sort of an amalgamation, if you will, of various things. Remember that clinical experience is just one part of clinical decision making, and it certainly should be the only part in making clinical decisions. We should be using evidence-based medicine. We should be using the knowledge we have from the medical sciences and basic sciences. And then we should always be aware of our biases, including the unconscious and conscious biases. All of these things together go into making a clinical decision about a patient and their care. And so I think this is important because if we rely too heavily on any one of these 4 things, we may find ourselves not practicing the best medicine. For example, if you only use clinical experience and do not use any evidence-based medicine, well, you fall into the trap of only treating sort of the patients that you see, and then you sort of don't think about, well, maybe the patients that I'm treating aren't representative of the entire population. So then you start kind of making up various claims about what patients do and how patients act and what helps patients and what doesn't help patients. And of course that can cause problems because you want to make sure that you're not just going off your own clinical experience and your own sort of subjective experiences making decisions, and you want to be able to look at the population as a whole as much as you can and look at the evidence. Not to mention you want to make sure that you have some foundation that you're making these decisions from, and that what that means is that if you don't have any understanding of the knowledge, if you don't have any knowledge of the basic neurosciences or the medical sciences, it's going to be very hard to make a clinical decision without that knowledge. In fact, it could be dangerous. But then again, if you're only going off the knowledge and not using any of your clinical experience, that could be problematic as well. So these are just the 4 things that I like to talk about before I speak about any sort of clinical decision, because we want to make sure that we're aware that all of these things come into play. So bias, stigma, and misconceptions. Probably my favorite part of this talk because I think it's important, and I think that many providers, patients, and the public in general have a lot of of misconceptions about adult ADHD and just ADHD in general and the treatment for ADHD. And so I think this is sort of an attempt to annihilate those claims that people make that just are completely fabricated and not based in any sort of clinical evidence, either neuroscientific evidence, basic neuroscience evidence, or evidence in the literature. So when I gave a talk, I gave a similar talk about a year ago at a conference in the desert. When I say the desert, I mean Palm Desert. And when I showed this slide, it didn't have Tom Cruise at the time. It had addiction medicine specialists. And I remember there was a provider in the audience who did not like that I said that, and didn't like this slide because it sort of made it seem like the ADHD specialists are against the addiction medicine specialists, and that's really not the point I was trying to make. The point I'm trying to make with this slide is that it's important that we don't lump methamphetamine, and when I say methamphetamine, I mean illicit use, street use of methamphetamine with prescription stimulants. Now, there is methamphetamine that you can get, that you can be prescribed. It's digoxin. Rarely is it used, but even so, we want to differentiate stimulants that are prescribed and street stimulants. And the reason why is because they're two very different things. Oftentimes when you're using methamphetamine on the street, it's laced with adulterants, all kinds of adulterants, organic solvents, things that are very toxic to your brain and to your body. And so that's one thing that it's a huge difference between street methamphetamine and prescription stimulants. The other thing is when people are using methamphetamine on the street, they're not taking it in capsules. Although I have had a few patients tell me that they would put their methamphetamine in capsules that they bought on Amazon as a way to sort of have a controlled release stimulant, which was kind of interesting. But majority of people are either smoking crystal methamphetamine or they're injecting it. And when you start injecting or snorting or using those methods or those routes of administration, you're really altering the pharmacokinetics of the drug. And the pharmacokinetics of the drug, or how the drug enters into your system and how long it stays there and how quickly your levels rise, ultimately impacts how you behave and what it does to you. So to say that smoking street methamphetamine is the same or has the same risk as taking a prescribed stimulant is just ridiculous. But unfortunately, when you look at the literature, a few studies actually differentiate the two. And when you see stimulants, you just want to be careful. You want to be careful when you hear stimulants in general, because you want to ask the question: are they including prescription stimulants and street stimulants, or are they just including street stimulants? Are they just including prescription stimulants? And so those are the things you want to ask whenever you're reading any sort of review or article on ADHD and the use of stimulants, or just stimulants in general. Okay, so now we're going to talk about the misconceptions and stigma associated with ADHD, and this is my favorite part of the talk, because now we get to talk about the most ridiculous things people come up with. First is everyone has ADHD. That's not true at all. When we say people ask me, don't you think everybody has ADHD? And the answer is no. Do I think that everyone to some degree, or most people have some degree of inattention at some point in their life? Yes, I do. I think that's a normal thing. But do I think that everybody experiences a debilitating disorder where there's significant dysfunction in their life because of their inattentive or hyperactive impulsive problems? No. The answer is absolutely not. I don't think everybody has that. And so it can be very, very invalidating and hurtful to tell somebody, for example, who's depressed, well, everybody has a little bit of depression. Well, that doesn't help the person that's depressed who's literally thinking about ending their life. Not everybody thinks about really ending their life. And so I think we got to be careful when we say these types of things, because it can be really, really hurtful for somebody who's actually going through it. So no, I don't think everybody has a disorder of attention. Most children grow out of ADHD. This is like one of my favorites because it's like we're treating ADHD like it's a Pampers diaper or like a pull-up, like you just somehow uh, grow out of it. It's like, I'm a big kid now. I no longer have ADHD. It's like, doesn't make any clinical sense. It doesn't make any neuroscientific sense. In fact, we know that over 2/3 of children who are diagnosed with ADHD go on into adulthood um, with ADHD symptoms and continue to have the diagnosis or to meet criteria for the diagnosis of ADHD. So that's just not true. ADHD is limited to males. Well, if you read the literature, you may think that ADHD is a predominantly male disorder, and that's just not true also. It is true that in childhood and adolescence, there is a discrepancy in terms of the prevalence of ADHD in males and females. Specifically, ADHD is diagnosed at a higher rate in males than in females. But what you don't realize is that typically in males, ADHD presents with the hyperactive impulsive type. Not always, but that's the most common type of males. And so these are the kids that are jumping up and down, bouncing off the wall, and they're the ones sitting in the back of the class, on timeout, and they're the ones that are picked out, and they get the diagnosis. However, women or females, this is not true. They have more of the inattentive type, and so they are sitting in the classroom. They're not jumping up and down, but they're still suffering with inattention, and they can't focus, or they're daydreaming, or they're not getting their homework done, but they're not getting picked up. And so what you see is over time, as you go in, as kids get older, the rates of ADHD in males and females begin to equalize, and in adults, it's almost 1-to-1. There's still a male, a tiny male predominance, but overall it's equal rates of ADHD in males and females and adults. And I would argue also in children, it's just that females don't get picked up. ADHD medications increase the risk of substance abuse. Man. So this is just, I don't know what to say about this other than it's just completely false. In fact, it's the opposite. Many studies have been done showing that untreated ADHD is a high risk for substance use, but medicated or treated ADHD decreases the risk of future substance use. So it just doesn't make any sense when people say that, oh, if I give you a stimulant or a medication that could be potentially, you could potentially abuse, I'm somehow going to increase the risk of your substance use. That doesn't make any sense to me, and certainly that's not supported by the literature at all. So when people come up with something like that, you have to ask, well, where did they get that from? And many times when I ask, and I do ask because I want to know where, I want to know, I want to stay informed, they say, well, I mean, don't you think that it makes sense that when you give somebody a stimulant, it's going to make them more likely to abuse the stimulant? And no, I don't. I don't know where that came from or why you think that, but that's just not true at all. Adults seeking treatment for ADHD are probably drug seeking. I mean, this is like, this is terrible because this is the reason why adults don't like or are afraid to report their symptoms or to report that they're struggling to their providers, because they think that the provider is just going to think that they're just drug seeking, and that's just awful. People ask me, well, don't you think that people, adults, or especially like young adults, are just interested in getting a stimulant because they want to party and have a fun time? And I think that that's true to some extent. There are people that do that. Humans are humans, and they do various interesting things. But do I think that we should just treat everybody that walks in the door telling us that they are suffering with inattentive symptoms, that they're just seeking stimulants. No, I think that that's terrible, and that's not something that that doesn't encourage people to get help. So no, when people come in and they say that they're having attention problems, the first thing I think of is ADHD possibly. I don't think of, oh, this person is just trying to get a stimulant out of me. That doesn't make any sense. I have more faith in people than that, and I certainly can use clinical judgment to know when somebody is probably seeking drugs, and maybe not. Maybe sometimes they're able to get their way and get the stimulant, but I'm not too concerned about people coming in and just seeking stimulants. I don't think that that's a huge problem. The long-term use of stimulants increases the risk of developing Parkinson's disease. This is just flat out stupid. This idea of Parkinson's disease came out of a few studies looking at the use of methamphetamine in like 1960s and 70s, and the abuse of dexedrine, or was it benzedrine? I forget exactly what it was, but I think it was benzedrine. But they were looking at the abuse of methamphetamine, street methamphetamine, and then prescription diet pills, and then the later risk of developing Parkinson's disease. And there was an increased risk, and that makes sense to me because street methamphetamine does kill dopaminergic neurons. It's toxic to dopamine neurons. But remember again from the very first part of the talk that stimulants is a very general term, and are we talking about prescription stimulants? No, we're not. Not at all. And so there's no evidence that prescription stimulants or long-term use of prescription stimulants increases the risk of any sort of movement disorder at all. Stimulant medications commonly precipitate psychosis and mania in patients with comorbid bipolar disorder or primary psychotic disorders. Now, you would think this makes sense and this is common sense, but again, it's not supported by the literature. This has been studied, and while there is a small risk of precipitating psychosis and mania in patients with not just bipolar disorder, but just any disorder, the risk is really, really small. It's relatively small, and in fact, there's some studies suggesting that the judicious use of low-dose prescription stimulants can actually really help people with schizophrenia, particularly with the negative the negative symptoms of schizophrenia, which are the most debilitating. So we often think of patients with psychosis that hear voices or have delusions or paranoid delusions as being sort of the real problem, but it's actually not. Treating the positive symptoms of psychosis is much easier than treating the negative symptoms, and the negative symptoms are, for example, the amotivation, the lack of affect, social isolation, all of those things, and the cognitive deficits that you see in patients with schizophrenia. That's what leads to the long-term dysfunction and disability. In fact, not the positive symptoms. So no, stimulant medications, they are associated with a very small risk of psychosis and mania in patients with comorbid bipolar disorder, but I have treated patients with bipolar disorder who are on stimulants and they do great. So I don't think that that's well supported. Study drugs equal cheating. No, they've done the studies and that's not true. Individuals who take these medications who have a diagnosis of ADHD perform better on neurocognitive testing or neuropsychological testing. So what I mean is they've looked at, in the past, they've looked at the use of stimulants in individuals with ADHD and before and after they're taking a test. And what they found is that in individuals with ADHD, they do better if they're on the stimulant. Now, they've also done this with individuals who don't have ADHD or don't meet criteria for ADHD. And what they found is that when you give somebody a stimulant who doesn't have ADHD and you do various neuropsychiatric testing, they think they do better, but objectively on the actual assessment, they don't do any better. So there's a big difference between perceived improvement and actual improvement, and that's been studied. So no, it's not cheating. And in fact, this whole problem with college students using or abusing or misusing stimulants, there's a reverse correlation between the use of stimulants and GPA. So what I'm saying by that is that the more stimulant use, the less or the lower the GPA. And how you want to sort of swing that and make sense of that, you can sort of take it, make sense of it how you want. But the way I look at that is, well, I think people who are abusing or misusing stimulants are probably not going to do great either way anyway. And so it's really not a cheating per se, I don't think. And then ADHD medications are damaging to the brain. That's just not true. And I'll show some studies at the very end that refute that. Okay, so common challenges, pharmacy issues. If you've ever been prescribed a stimulant, you'll know that many pharmacists will treat you like a drug addict, but it'll be very hard to get your stimulants on time. They often have to order it. Many times, if you go in and give your prescription, the pharmacy will basically tell you, "Oh, we don't carry that medication," or they'll sort of, give some. It's just it's hard to explain, but if you've ever been to a pharmacy and you've handed over your prescription stimulant, your prescription for a stimulant, you'll know what I'm talking about. So that's really an issue. Insurance issues, man, it's always hard to get this stuff covered. You always have to go through a prior authorization, particularly for the newer agents like Vyvanse or the extended release formulations. It's a lot harder to get those, particularly in the sort of Medi-Cal, or I should say the Medicaid, Medicare population. It's very, very hard to get those medications approved. Then from the patient's perspective, if you're prescribing a stimulant to a patient, you want to tell them to really hide their medication, because there are often pressures to sell or give away their medicines if somebody else finds out that they have them. And so that's an important thing, and that can be really, really distressing for somebody who feels like they're really benefiting from their stimulant. They're doing much better now. And then you got all these friends asking, "Well, could I get one? Go, give me one. I'll sell that stuff." That can just be an additional stress. And then many clinicians feel uncomfortable diagnosing ADHD compared to other disorders, and it's mainly because of liability concerns. I think it's one, discomfort with the treatment of ADHD, but also there's worried, they have sort of unsubstantiated fears about what these stimulants are going to do or how it's going to look if they prescribe a stimulant, which I think is unfortunate, because many patients often will tell me, for example, that they present to their primary care doctor, who, by the way, primary care doctors are the most common. So mental health in the United States, at least, is most often treated or managed by primary care doctors. Primary care doctors they do everything, and so when patients present to their general practitioner, their primary care doctor, and they tell them that they have these concerns, it's very rare that you find a primary care doctor that is willing to prescribe a stimulant, even if they meet the criteria for ADHD. Of course, diversion and abuse of medications is a problem. There's a lot of data on that, so especially in the college population. Why that is, we don't have time to talk about, or what are the theories behind why that is. We don't have time to talk about it, but that is a real thing. But most importantly, I think the biggest challenge is that the overgeneralization of research findings and unsubstantiated conclusions often mislead clinicians and the lay public. And so that's just so true. I mean, people will make up claims, they'll make statements, and it's just, I don't know where they're coming from. I ask how they know that or where they got that information from, and I'm often left with, well, that's just what I believe, or that's just what I think. And to me, it's like, okay, if you're going to make a statement like that, I would hope that it comes from some sort of either an evidence-based approach or something supported by science, and many times it's not. So anyway, those are the most common challenges with ADHD and the treatment of ADHD. So the last thing I want to do is talk about a case that I introduced in the very first lecture. This is the case of LB, and we're going to go through the initial part very quickly. So LB is a 54-year-old single woman referred for depression and anxiety. She reports having chronic and persistent low mood, lack of motivation, concentration problems, irritability, severe insomnia, the initial type, fatigue, anxiety. She was often ruminating. She was catastrophizing. She had racing thoughts that did not follow any pattern at all. She couldn't identify any sort of episodic pattern. She experiences intermittent passive suicidal thoughts. She finds herself in bed a lot with significant procrastination that she has trouble explaining, but that worsens with her anxiety symptoms. The only pattern she identified was that her mood, low energy, irritability, and insomnia seemed worse during the winter months. She started a new full-time job as a sales consultant, which is her passion, 1 year ago, or 1 year prior to when I saw her. By the way, this was last year that I saw this patient. So she started a new job 1 year prior to the visit, and she reports significant worsening of all symptoms since starting her new job. So the primary care doctor started Wellbutrin and titrated it up to 450 milligrams daily. This is common. People who go to primary care or even psychiatrists or nurse practitioners, they will prescribe Wellbutrin as a non-stimulant medication for ADHD, or they'll prescribe atomoxetine, which is Strattera. So this is very common. So Wellbutrin was started. It was titrated up to 450. There was a small improvement of fatigue and motivation with Wellbutrin, but there was a minimal change in her depressed mood. Her concentration, her irritability remained, her anxiety symptoms remained, and her insomnia remained. Trazodone was then added 2 months later for insomnia and anxiety, with minimal response except morning sedation, drowsiness, and orthostasis, which is orthostasis or orthostatic hypotension is when you give somebody a medication, and when they are laying down and then they sit up or stand up, their blood pressure doesn't, or the mechanism for their blood pressure is sort of off, if you will. In other words, when you're laying down and then you go to stand up, your body should be adapting to this change in such a way that your blood pressure increases, so that way you don't faint. Well, some medications will block that mechanism. For example, Trazodone is one, and then many of the beta blockers can do that too. And so she was experiencing significant dizziness, lightheadedness when she would stand up, and this is common with Trazodone and many other psychiatric and medical medications. So her work involves meeting with clients throughout the week and completing reports which have strict deadlines. She reports struggling with starting and finishing these reports, but also says, "My life is one big disorganized desk drawer. I lose papers all over I lose papers all over my house. I constantly forget why I started doing something. My friends get frustrated with me because I'm always having to go back and get my forgotten belongings, and they tell me I talk too much and don't listen. I try to listen, but it doesn't stick, or I end up realizing that I'm watching their mouths move and wondering why they chose that lipstick." And I thought that was funny because, well, it's not funny for her, but I think it's very classic. Is that, if you've ever, if you have ADHD, or you've been around somebody who has a diagnosis of ADHD, or you suspect has ADHD, what you'll find is when you're talking to them, they'll sort of just stare at you and they'll sort of just stare at you or through you rather than listen to you. And this is something I do, certainly I've done many times. You just sort of sit there and sort of stare at them, and then when they're talking, you're like, "Oh shit, I'm not really paying attention to what they're saying. I'm just kind of looking at their lips And then you're like, oh, that's kind of weird lips. And then you just kind of keep talking, and keep thinking this to yourself, and then by the time they ask you a question, you're like, oh crap, I don't know what, I'm not sure what they asked. So you just kind of like nod your head. But this is a common problem in people with ADHD. Friends also get annoyed because she interrupts others, she talks over others, she talks rapidly or derails conversations. This was very evident during my first interview with her. It was like very difficult to get anything out of her because she would start talking about one thing and then she would jump all over the place, and I was just like, oh man, I need some basic information here, and it's very hard for her to tell a very linear story without getting sidetracked and talking about something else. So in her past, she had extensive abuse, sexual, physical, and emotional abuse during childhood between the ages of 5 and 7 years old. Um, her father and neighbor were the abusers. And then she was also abused later in the 2 marriages that she had. So she had PTSD symptoms, including hypervigilance. She was very hyper aware of her surroundings. She had very anxious paranoia. When I say anxious paranoia, I don't mean paranoid delusions, like, that she's got this fixed belief that the government is after her, or that there's some, ridiculous, unrealistic type of delusion. This is like she's anxious, understandably anxious, because she had been assaulted many times, and now she's sort of on alert and worried about everybody's intentions. That's not delusional paranoia, and that's one of the main reasons I think people with PTSD or severe PTSD get labeled as having schizophrenia or some other psychotic disorder, because they have quote-unquote paranoia, but the paranoia is understandable. It's an anxious type paranoia. It's not a delusional paranoia. She had nightmares, and she had all these things mainly in the past, and they're less prominent now. So in her past, she had heavy alcohol use and methamphetamine use. This was in her early 20s, and this went on for about 3 or 4 years. She's had no substance use in the past 3 years, except occasionally cannabis for sleep, which helps, sometimes, but not always. And she's had no manic or psychotic symptoms while sober, no suicides, self-harm behaviors, or violence in the past. Her first hospitalization was in 2016. It was her first and only hospitalization in her whole life. She was put on a 5150, which is our California's welfare institution code for involuntary commitment. So she was on a 5150, which is a 72-hour involuntary hold for suicidal thoughts. This was the first encounter with psychiatry. So all those years, she had never seen a psychiatrist. Previous medication trials, when I saw her, included fluoxetine, which is Prozac, venlafaxine, which is Effexor, lorazepam, which is Ativan, paroxetine, which is Paxil, duloxetine, which is Cymbalta, bupropion, which is Wellbutrin, trazodone, which is Deseril, sertraline, which is Zoloft, citalopram, which is Celexa, and methylphenidate for 6 months in 2003 to 2004. So she had been on all those different medicines, and none of them significantly improved her symptoms. She was born in Temple City, California. She was 2 weeks premature. Her parents were very active in church, but emotionally and physically abusive and condescending. They did not believe in mental health treatment, and so she was not allowed to seek counseling or therapy. She had poor performance in elementary and high school. She was always in trouble. She said she had problems with speech, and she had issues reading. She thinks that she was diagnosed with dyslexia, although she didn't have any sort of formal assessment for dyslexia, because again, her parents were against mental health or anything to do with mental health. She dropped out eventually, and her parents, again, were not very supportive. Eventually, she went back for her GED. She's been involved in multiple relationships. She's been divorced 2 times in the past. Her first marriage was at 18 years old, and she was divorced at 21. She has 3 children from her first husband. From 21 to 24, She was in a toxic relationship. She was introduced to drugs and was sexually and physically abused. In fact, the man that she was with prostituted or encouraged her to prostitute for money during this time so that they could use drugs. She eventually left him after she found out that he had been molesting her daughter. So this was just an asshole of a guy. She just got kind of sucked into this relationship, and this seems to be a pattern for her throughout her life. She was married a second time around 24 years old, and this was a 17-year marriage, but it was also extremely abusive, and she also divorced, got divorced also from this marriage. So she eventually turned to religion, and she said that it has completely changed her life. She met a man 1 year ago, so this is now going to be 2 years since it was last year. So she met a man about 2 years ago. She's engaged, and she lives in Bloomington, California. She doesn't actually live in Bloomington, California. I had to change the location for her privacy. But she lives out in sort of central, Southern California, and it's sort of the eastern part of California. Her medical history included asthma, carpal tunnel, COPD, irritable bowel syndrome, and fibromyalgia. And her only medications were ibuprofen and albuterol. She had been on all those medications before for her psychiatric symptoms, but she was very hesitant about medication because she didn't like the idea of being on medicine. This was her adult self-report scale symptom checklist, and I just wanted you to see this because if you notice, the shaded boxes, by the way, the more X's that the more X's that the patient puts in the shaded areas in both Part A and Part B, the more likely the diagnosis. This is not a diagnostic tool. This is not used to make a diagnosis. This is really a screening tool and a way to sort of to see, are there some inattentive impulsivity, hyperactivity type symptoms going on that could suggest a diagnosis of ADHD, but this is not a formal diagnostic test. There isn't a formal diagnostic test for ADHD, but you can see that she really meets, or she really has a lot of symptoms of ADHD, both the impulsive and hyperactive symptoms, which are mainly characterized in Part A, and then also the inattentive symptoms, which are, I'm sorry, it's the other way around. So the Part A is more of the inattentive symptoms, and then Part B is more of the hyperactive impulsivity type symptoms. So what I did with her, I started her on methylphenidate, and this was controversial because she had a significant history of methamphetamine abuse. But I started her on a very low dose at 10 milligrams every morning and 10 milligrams at noon. This went on for about a month. Then it was increased to 10 milligrams in the morning and 20 milligrams at noon. And then we planned to eventually, once we found the right dose of instant release stimulant, we were planning to switch over to the extended release. She also started CBT with a therapist. So, over time, she, responded very well to the medicine. In terms of her outcome, she reported significant improvement in sleep, significant improvement in her attention, internal restlessness. Her motivation was back. She had little fatigue. She was less emotionally sensitive to environmental triggers. She said that her IBS, or her irritable bowel syndrome, really had kind of dampened, almost gone away. She had less flare-ups. She was much more organized and productive at work. She presented, God, it was incredible when she came back. So when I first saw her the very first time, she was very depressed. She was sort of wearing clothes that suggested that she just kind of rolled out of bed, and she was just barely making it through the day, and she wasn't working. And when she came back, and it was like a few months after I've seen her, she came back and she was wearing just full work attire. Her affect was bright. She was just a completely different person, and she was tearful, but in a happy way, with how this medication has changed her life completely. And so that was really rewarding to see. She was also not using any marijuana at all, and she had no cravings at all for methamphetamine, which she had before. And then so we plan to switch to the extended release methylphenidate eventually, and she is still on that dose and doing great. So just some final concluding remarks. ADHD criteria have been updated in DSM-5 to reflect the chronic nature of the disorder. Increased attentional demands and decreased hyperactivity and impulsivity in adulthood may explain the epidemiological shifts throughout the lifespan. So in other words, as we get older, the demands on us for our attention and our cognitive abilities increases as we're sort of attending to adult type things, right, in life. And if you're somebody who had ADHD or symptoms of ADHD in childhood and you weren't diagnosed, as you go through life and the demands increase, your dysfunction can also increase. And so that could be a reason why we're seeing that increase in ADHD diagnoses in adults. Undiagnosed ADHD may lead to severe impairments in multiple life domains. And then the stigma and misconceptions often remain a challenge. The optimal management of adult ADHD involves a multimodal approach, which we discussed in previous lectures. These are the references for the talks. And then some very final remarks. I just wanted to bring up a few things. Biofeedback is an interesting phenomena, a great treatment option that's now sort of being looked at for ADHD. Essentially what this is it's called neurofeedback. And so what you do is you put these electrodes, EEG electrodes, over your scalp, and you can actually see your brain waves. And essentially what happens is you get to see your brain waves. And in individuals with ADHD, it's thought that that there are too many what we call alpha waves. And so what we want are beta waves, because beta waves are the frequency pattern that produce that we see when we're alert and concentrating on a task. But in individuals with ADHD, they have much more alpha waves, and alpha waves are much more sort of the waves that you see when you're sort of not attentive and you're sort of just in your thoughts. And so the goal of neurofeedback is that you can actually see your waves on the screen, and you can sort of try to focus on a task, and then see it change, to beta waves on the screen. And so over time, you can sort of train yourself, sort of like mental weight training, to get more of those beta waves. This talk wouldn't be complete if I didn't bring up the recent article in New England Journal of Medicine that said that psychosis is associated with methylphenidate and amphetamine. And I just want to point out that while this is a good study, the outcome I think is important to know, because people will see this and think, oh man, methylphenidate and amphetamine increase your risk of psychosis if in patients with ADHD, and that's just not at all what the study really concluded. And so I want to quickly review. So this is just the results, and I think it's important to know what the conclusions were. So among adolescents and young adults with ADHD who are receiving a prescription stimulant, new onset psychosis occurred in approximately 1 in 660 patients. That's 1 in 660 patients develop new onset psychosis with a stimulant. It's very low. It's a very low risk. So, and this is a study that looked at 337,919 adolescents and young adults. So out of all of those, out of the total of 337,000 individuals that they were looking at, there were a total of 343 episodes of psychosis. I mean, that's like not that much, right? So, they also mentioned that it seems that the amphetamine group, or that amphetamines increase your risk of psychosis more than methylphenidate. But again, both are still very, very, very low. But then you look at this study, which is another study that came out, methylphenidate and the risk of psychosis in adolescents and young adults, concluded that based on their research, this is the conclusion. Contrary to clinical concerns, we found no evidence that initiation of methylphenidate treatment increases the risk of psychotic events in adolescents and young adults, including in those individuals with a history of psychosis. Our study should reassure clinicians considering initiating methylphenidate treatment in ADHD in adolescents and young adults, and it challenges the widely held view in clinical practice that methylphenidate should be avoided or its use restricted in individuals with a history of psychosis. This is a great study, by the way. I really dissected this one, but I think they do a very good job. The New England Journal of Medicine is also that was a great study also. Although the conclusion, people I think misinterpret the conclusion of those studies. And then this study looks at antidepressant associated mania and psychosis resulting in psychiatric admissions. Now this is a much smaller study, much smaller. It's hard to compare the two studies because this is an underpowered study, very small sample size. But I wanted to, so in that first study in the New England Journal of Medicine, it was 1 in 600 and something patients developed psychosis or developed psychosis, and in this study, antidepressant use, 43 patients of a total of 533 were found to have psychosis associated or mania, psychosis or mania associated with antidepressants. So this just shows that maybe there's a higher risk of psychosis and mania with our antidepressants there is actually with stimulants. Although it's hard, you can't make that conclusion based on comparing the two because they're completely different studies and different sample sizes and different samples in general. But I think it's interesting that when you look at the literature, there's a wide range of numbers, and more often than not, you'll find that with stimulants, the risk of psychosis and mania is much smaller than other medications used in psychiatry, which I think is interesting. This is just another one, same idea.